The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. This is Bethany O'Connor from HP Plus. We are going to get started in about 2 minutes. We are so glad you're here. We've got a great show for you today. And I'll see you back here in 2 minutes. Thanks. All right. Hello, everyone, and thank you so much for joining us. This is Bethany O'Connor from Health Policy Plus, and I am absolutely delighted to welcome you to today's presentation titled Our Family Planning Programs Reaching the Most Disadvantaged, an Equity Case Study from Uganda. We have a fabulous broadcast for you today, and we'll begin with just a few announcements. So first, this broadcast is being recorded, and we will post the recording on the HP Plus webinars page, and that link will be included in the follow-up email you'll receive from us. Next is we would love to hear from you, and we welcome your questions at any time. Please submit your questions via the chat box on the right-hand side of your screen, and I will read them aloud when we pause for questions. And we've allowed plenty of time for questions at the end, so please do just tell us what's on your mind. Ask anything you want to our presenters, and we look forward to that discussion. Next is these web conferencing platforms are getting an unusually high amount of traffic, as we all know, because of COVID. So we just ask that you bear with us in case we encounter any technical glitches. We'll get it fixed and we'll get the presentation back up and running. So thanks in advance for any patience needed there. And finally, we just ask that if you're not speaking, that you kindly mute yourself to keep the line nice and quiet while others are talking. And that concludes the little announcements portion. So let's meet our presenters. Next slide, please. Our presenters today are Sarah Stratton, Kaya Yurchinska, Kevin Ward, Shiza Farid, Lubov Teplitskaya, and Dr. Jay Gribble. Now that we have met our panelists, I will now turn it over to my colleague, Sarah Stratton, to start our webinar today. Sarah?
Good morning, afternoon, and evening to everyone, and welcome to our webinar. The next hour promises to be very informative and thought-provoking. As you can see, our agenda today, we will have 6 segments, beginning with an introduction, a background on inequity in health, healthcare, and family planning, followed by an overview of HP Plus's new approach for diagnosing inequity in family planning programs, and then results from the application of this approach in Uganda, a closing, and finally, your questions and answers. Next slide, please. To start us off, I'd like to share a few thoughts about equity within development. The development community has spoken about the importance of equity since the 1940s, and the FP community has purposefully sought to improve equity in access to contraceptives and family planning services for over 50 years. In the last 20 years, eliminating inequity has been the focus of the Millennium Development Goals, the Sustainable Development Goals, and universal health coverage, all with the goal of leaving no one behind. For example, we've attempted to closely examine differences in outcomes by subgroups central to the SDGs, though we are still constrained in being able to do that due to data collection limitations. Likewise, universal health coverage seeks to improve equity in access to services through reducing disparities in coverage of health interventions and financial protection. We know that many of the differences observed thus far arose due to unfair or unjust circumstances. Within the FP arena specifically, Equity is a guiding principle of the FP High Impact Practices Partnership and a key element of rights-based services under FP 2020. In 2015, the HIP Technical Advisory Group started asking questions such as, what are appropriate methods for making claims of increasing equity? How can we know that we are actually reaching the underserved or most disadvantaged populations? How do we measure equity? And how exactly is equity defined in our community? There weren't clear answers to these questions, but we are making progress through different channels to answer them. Another important issue is, as we'll hear during this webinar, the ways in which we've examined and identified inequity has had some limitations, including that we've focused heavily on economic dimensions of equity, excuse me, rather than considering broader dimensions, such as the range of statuses and characteristics by which people vary. We are going to learn about HP Plus's new approach for diagnosing inequity in family planning and how this information can be used to improve FP programs. Now I'd like to pass the floor to my colleague Kaya, who will provide some background for us on inequity in health, healthcare, and family planning. Over to you, Kaya.
Thank you very much, Sarah, for that introduction, and welcome everyone. Before we share more about HP Plus's new approach and our Uganda findings, let's first review some inequity fundamentals. So to begin, what is inequity? Inequity speaks to differences between groups of people that are crucially avoidable, unfair, and unjust. And as you can see, these are more than just pure differences between subgroups, which would fall more so in the domain of inequality. Inequalities often arise from natural biological variation, whereas inequity is an ethical concept in which we're making judgments about whether situations are unfair and unjust. And as you can imagine, there are several criteria for considering what is or isn't an inequity, but one that can be used is the extent to which choice was really involved. And if something was out of your direct control, whether a solution is out of your direct reach, that would point to an inequity. As many have recognized today, distinctions between these two terms of inequity and inequality aren't always clear at all. In some cases, we see that inequality is used to capture just basic differences, even when something actually is unjust or inequitable. And in other cases, we find that inequality is oftentimes used to mean inequity. In our approach here, we refer to differences as inequities. And this is definitely going to become clear in the subsequent slides, but we assume that the majority of differences we observe in family planning are in fact avoidable and unjust. Realistically though, sometimes these differences are due to overt discrimination, but oftentimes they're driven actually by much more subtle structural barriers, the effects of which we really shouldn't underestimate. Equity itself originates from the right to the highest attainable standard of health. And there, equity in health means that everyone has a fair opportunity to reach their health potential, regardless of their wealth, their education, their gender, their age, race or ethnic group, residence, disability, or other status, period. But this is different from equity in health care, which pertains to the programmatic elements that actually shape those health outcomes. And there are 4 interrelated and essential elements of healthcare to which people are entitled, and they're very well known. So I suspect that all of you will have already heard of availability, accessibility, acceptability, and quality. And really, for a holistic approach to interrogating equity in health, you not only need to be concerned with outcomes, but really with these essential elements as well. The right to health includes family planning, information services, and supplies. Importantly, equity in family planning doesn't necessarily mean equal use. The use of family planning is actually equitable only if it adheres to free choice and reflects need. But for free choice to exist and for equity within family planning, we have to take into consideration to what extent subgroups experience equity in, again, those 4 core dimensions: availability, accessibility, acceptability, and quality of information services. And this holistic perspective is perhaps best articulated by the FP 2020 Rights and Empowerment Working Group, who wrote a few years ago that individuals, as you can see in the box here, individuals have the ability to access quality, comprehensive contraceptive information and services free from discrimination, coercion, and violence. Quality, accessibility, and availability of contraceptive information and services should not vary by non-medically indicated characteristics such as age, geographic location, language, ethnicity, disability, HIV status, and so forth. In other words, equity needs to be interrogated along components that are just beyond use itself. And I think this point was the point about examining inequity beyond uptake alone, and also many other recommendations for family planning equity exist within the discussion paper that you see on the right here, which is on equity for the High Impact Practices Partnership. Now let's take a closer look at AAAQ, or availability, accessibility, acceptability, and quality of care in family planning, and what it actually looks like in practice. So we're not going to go over each of these definitions, but they're going to be available to you in this slide deck, which will be posted on the HP Plus website. And if you'd like to explore these further, you can take a look at the conceptual framework on voluntary family planning programs that respect, protect, and fulfill human rights. But as an example, let's take a look at accessibility first, which includes 3 domains, as you see here. So what family planning should look like is family planning should be available within a safe geographic and physical reach for all. Secondly, commodities and services should be provided at no cost, or such cost that ensures that nobody is disproportionately financially burdened. And finally, everyone can access evidence-based family planning information consistent with need that actually takes into consideration your age, your language ability, your reading ability, your disability, and other status. Another example that we talk about quite a lot is acceptability, and what this means in practice is that family planning information, services, and commodities are respectful of culture, and they're sensitive to gender, age, disability, sexual diversity, and other life cycle requirements that evolve. So what are some real-world examples of inequities within these components? And for that, we're going to take a look specifically at accessibility. So an inequity example is a program that produces and distributes family planning brochures or family planning information that features really complex explanations in only one language in a community in which many languages are spoken, and actually a large share of individuals are illiterate. Another example is facilities that are simply inaccessible for women who are physically disabled. And another example, or final example, is a situation in which your family planning consumables, so the consumables required, let's say, for implants and IUDs, have to be paid for by clients, and they are cost prohibitive for low-income women and families, which curtails their contraceptive choices. Despite the increased focus on addressing inequity in health and family planning programs, we still don't have a replicable approach that can be easily used to identify inequities. So one common limitation that we've found of existing approaches is that, as Sarah mentioned, they're too focused on the wealth difference in family planning without really looking, again, at those broader range of characteristics and statuses by which people vary. Another limitation is that studies have been too focused on program outcomes, such as modern method use, rather than AAAQ, rather than those programmatic components. We also found that most analyses focus on quantifying inequities nationally, with really little or actually no attention to those subnational realities. And we know that this is actually the level at which the vast majority of programming decisions for family planning are made today. And importantly, the methods that do exist kind of seem to be concentrated in the realm of research and aren't really readily replicable for programming and easy use by everyone. So in response to these limitations, the Health Policy Plus project developed a replicable approach for diagnosing inequity in family planning programs. And to tell us more about this approach, I'm now passing it on to Kevin.
Thanks, Kaya. Now that we understand the concept of inequity in the context of family planning and some weaknesses of existing methods for identifying it, I'll take you through the approach we developed for diagnosing inequities in family planning programs. Next slide. We selected an approach that could identify inequities for a range of commonly disadvantaged subgroups, so not just limited to the poorest women, for various components of family planning, not limited to use, and at the national level, as well as across and within each subnational region. Identifying inequities in this way answers the who, what, and where of inequities in family planning. Who is experiencing the inequities? What components of family planning are not being delivered equitably? And where, geographically, is the inequity occurring? This level of specificity is key to guiding decisions around funding, design, and implementation of both national and subnational programs. We also wanted the approach to be relatively simple and easily applied in any country with a demographic and health survey. To facilitate that, we wrote the code in R, which is a free statistics software, and we will be making it available online along with an Excel sheet to facilitate interpretation of results. Next slide. So what is the method exactly? Essentially, it is a series of multivariate logistic regressions run for each of 5 different components of family planning at the national level and within each subnational region. Every regression compares the odds of receiving a given component for 7 disadvantaged subgroups of women of reproductive age and their counterparts. If one subgroup has significantly worse odds of receiving that component compared to their counterpart, we would consider that an identifiable inequity. And for this analysis, we set the significance level to 5%. Next slide. As I just mentioned, each regression compares 7 different subgroups of women to their counterparts. These are presented here. First, we have the least educated women, which is women with primary education or less, compared to women with more education. Then we have the youngest women, which is women aged 15 to 19, compared to women aged 20 to 49. The poorest wealth quintile compared to the richest quintile. Women not in a union compared to women in a union. Women who do not belong to the largest ethnic group in their region versus women who do. And similarly, women who do not belong to the largest religious group in their region versus women who do. And finally, women who live in rural areas versus women who live in urban areas. There were other subgroups that we had wanted to include here, women with disabilities, for example, but we were limited either by the questions available in the DHS or by sample size. Next slide. I also mentioned at the top that we ran the national and subnational regressions for 5 different components of family planning, which are each presented here. After a thorough review of the DHS questionnaire, we determined that these 5 components best captured the various dimensions of the right to family planning. For accessibility, we have 2 measures, one for access to information and one for access to services. Access to information is gauged by a woman's exposure to any form of family planning mass media, be it television, newspaper, mobile, or radio. For access to services, we looked at whether a woman was told about family planning by either a provider at a facility or by a community health worker. We identified an acceptability issue if a woman says she is not using family planning due to opposition from family, her community, a partner, or even if the woman is opposed themselves. Quality is assessed with the Informed Choice Index, which asks family planning users if they were informed about possible side effects of their method when they received it, informed about what to do if they experience those side effects, and told about other methods available. Finally, we measured use of family planning in terms of whether a woman's demand for family planning is satisfied with modern methods. Here, demand is defined as the desire either to have no additional children or to postpone the next child. Importantly, this list does not include all concepts of family planning equity. Notably, it leaves out availability and financial accessibility. All concepts that we left out either lacked adequate survey questions or did not have enough observations. With that, I'll pass it off to Shiza to discuss how to interpret and how to use the results that our analysis produces.
Thank you, Kevin. I will be going over generating findings, interpretation, and replicability. So for Uganda and for any country in which this approach is applied where subnational data are available, 3 levels of results will be generated, corresponding to the questions this approach can answer. First, the results at the national level provide us with a high-level overview of inequities. Then there are 2 ways to look at the results subnationally. First, you can assess the distribution of inequity across subnational units to really understand where inequities are found. And secondly, you can look within subnational units to examine which subgroups are affected and for which components of family planning. Regarding the interpretation of results, we will mention that there will be cases where there are no statistically significant inequities. This does not mean that conditions are necessarily equitable. To round this point out more, I'll share 2 examples. First, there might not be enough of a sample size to assess inequities. For example, in the region of Karamoja in the northeast of Uganda, for 2 of the family planning components, we could not identify inequities because we restricted running the models to areas where at least 100 women were interviewed. Secondly, models are not always perfect. An inequity may not exist in the way we've defined and chosen to measure a family planning component, but may exist for those who define family planning and measure inequity differently. Moreover, there are some additional limitations to consider with this approach. The subnational analysis is limited to the survey sampling of the DHS, and we can only go as far down as levels at which survey is representative. This may not align with levels at which all decisions are made. Similarly, the measurements we use to represent each family planning components and the subgroups we study are constrained by what is available in the questionnaire, like Kevin has already mentioned. We would have liked to include other metrics and subgroups, but we're unable to. Even with these limitations, we believe this approach is rigorous, replicable, and highly relevant for policy and programming across different levels of decision making. And we will be making the user's manual, which will include guidelines, the R code, and the Excel sheet for interpretation available to apply this approach in different geographies. The R output will allow users to obtain 3 things. First, it will allow users to get the regression results. It will allow users to get visualization of these results via maps and simple graphics. The Excel sheet that Kevin mentioned will help with interpreting the R output of regression results. Next slide, please. So how can these findings be used? Findings generated through this approach can be used to improve family planning policy, funding, and programming decisions. From the policy perspective, results can be used as evidence for post-FP 2020 commitments and family planning costed implementation plans, helping ground who should really be the beneficiary of efforts. From the funding perspective, findings can be used to justify resource mobilization efforts and the prioritization of limited funds across program activities and beneficiaries, particularly across subnational units. And finally, this approach can be used as evidence to design more tailored interventions that are responsive to the unique needs of each subnational unit. Additionally, I will mention this approach provides us with a unique opportunity to improve the next round of costed implementation plans, as this level of detail does not currently exist. Current costed implementation plans largely examine inequities through descriptive statistics from the DHS and do not modify activities to suit the equity needs of subnational divisions. Next slide, please. Now we will take a look at the results for this approach for Uganda using the 2016 Demographic Health Survey. First, we will say a few words about the family planning context in Uganda, and then we'll show results across the 3 levels I have just described. Again, those are results at the national level, results across the subnational units, and then results within subnational units. For this segment, I am passing it off to Luba.
Thanks so much, Shiza. Contraceptive use across Uganda has increased substantially. Over the last decade, modern method use has nearly doubled, and Uganda has made a number of commitments to improve its family planning program. This has included proposing equity-sensitive activities in its family planning costed implementation plan for 2015 through 2020. While this progress and political will is laudable, Uganda has not yet met its family planning goals, which expire this year. As a result, many women across Uganda are still not receiving the quality information and services to which they have a right. To provide support in the next phase of family planning programming, we have applied the HP Plus approach for diagnosing inequity in family planning programs to Uganda to better understand who is underserved, for what component of family planning, and where. Next slide, please. In the figure on the left, each row represents a disadvantaged group, and each column indicates a family planning component. In Uganda, the least educated, the poorest, and unmarried women experience highly inequitable conditions. That is, they experience inequities compared to their counterparts in each component of family planning that you see here. And we can see this by looking across the rows in the graphic. By comparison, women who live in rural areas and religious minorities experience relatively equal conditions to their counterparts in the majority or all of the components of family planning. It is also common for disadvantaged groups to experience inequity across all family planning components, both the essential elements of care and demand satisfied. However, there are 3 components of family planning in which inequities are especially common. Looking at the graphic from the column perspective, the largest number of underserved groups are disadvantaged in the exposure to mass media, the experience of opposition to use or the lack of FP acceptability, and in satisfying demand for family planning with modern methods. Next slide, please. This graphic highlights the regions in which at least one subgroup experiences inequity by family planning component. The rows represent the regions and the columns represent family planning components. As you can see, inequity in family planning is pervasive. It exists in at least one component of family planning in each of Uganda's subregions, as seen across the rows in the graphic. In Bugishu and Bunyoro, underserved women experience inequity in every family planning component. In other words, they are less likely than their counterparts to have access to family planning information, access services, not be constrained in use of family planning due to acceptability, to experience quality family planning, and to satisfy their demand for family planning with modern methods. Across Uganda's subregions, there are 2 components of family planning for which inequities are most common, both relating to accessibility. Nearly every subregion experiences inequitable access to information and services. Next slide, please. Let's take a closer look at one of these components, specifically acceptability as it relates to family planning information. From the DHS, we know that the share of women who received family planning messaging through mass media campaigns varies widely across Uganda subregions, from 54% in Lango to 82% in Kampala. However, these descriptive findings do not provide context on the specific subgroups within each region that may experience significant inequities in access to FP messaging. Our approach allows us to identify these inequities. Despite the relatively high levels of family planning media penetration in some subregions, we can see from this map that inequities are common. In Kigezi, 4 subgroups are less likely to be exposed to mass media than their counterparts. By contrast, there is no inequity with respect to exposure to mass media in Karamoja. As you can see on the chart on the right, across all of Uganda's subregions, inequities among the least educated and the poorest women are most common. Next slide, please. From the DHS, we know there is significant variation in family planning demand satisfied across subregions, ranging from 27% at lowest in Karamoja to 65% at highest in Kigezi. Compared to the findings for access to information on the previous slide, we can see from this map that inequities in demand satisfied are less common. In 1/3 of subregions, we do not see any significant inequities in demand satisfied. In the remaining subregions, at least one disadvantaged subgroup is less likely to have demand satisfied compared to its counterpart. As you can see in the chart on the right, when looking across all of Uganda's subregions here, inequities among the youngest women are most common. Next, let's take a look at the findings within specific subregions. Next slide, please. As you can see in the figures on this slide, our approach allows us to examine FP inequities within each region in Uganda. We chose to profile Bugishu and Bunyoro because they're the 2 subregions in Uganda where at least one disadvantaged subgroup experiences inequity in each component of family planning. We see that the profile of inequity differs in these subregions. Specifically in Bunyoro, ethnicity is a much more common domain in which women experience inequity than in Bugishu, where inequities across ethnicity are less common. In Bunyoro, the ethnic minority experiences inequity in 4 of the 5 FP components. Use of these results could allow governments to better tailor family planning interventions at the subnational level. For example, developing family planning campaigns specifically to target the ethnic minority in Bunyoro. In Bugishu, we do not see inequities concentrated for one disadvantaged group. Rather, we can see that the youngest women experience inequities in family planning acceptability and in demand satisfied. Unmarried women also experience inequities in 2 family planning components, specifically in access to services and in receiving quality family planning care. Applied to Uganda, HP+'s new approach for diagnosing inequity in family planning programs demonstrates that inequities exist across a broad range of disadvantaged women. Inequities also persist in all family planning components and exist in every subregion. While there is wide variation in the subgroups who face inequities by component and subregion, our high-level case study results indicate that the least educated, poorest, and unmarried women require additional support across all components of family planning, and that the greatest challenges to achieving equity exist in accessibility. As we saw in our results, the inequity profile of each region is very different. Developing adequate recommendations and solutions requires a close examination of findings by and across regions. Given that we do not want to generalize recommendations here, this analysis provides evidence that can be used by district governments in Uganda to develop equity-sensitive family planning activities and tailored campaigns. In addition to better prioritizing family planning interventions across subgroups, subregions, and components of programming, Multi-sectoral approaches are needed to reduce poverty and improve education outcomes, which still serve as two core determinants of family planning outputs and outcomes. Now I'll pass it over to Jay for some closing comments. Thank you.
Thanks, Lyubov. At the start of today's webinar, Kaya talked about inequities as being the avoidable, unfair, and unjust differences that exist among subgroups. Many family planning interventions have the goal of removing inequities, but it isn't clear that they really do. This situation prompted the writing of a discussion paper to examine measurement of equity by the HIP tag, as mentioned at the opening of the webinar. Today, we've seen a systematic approach to looking at equity. It recognizes that equity is a complex issue and that we need to think beyond just use of family planning as the basis for considering whether equity is being achieved. The methodology drills down to consider accessibility, acceptability, availability, and quality in addition to use. Refining the dimensions along which inequity is found can help programs better address it. Often, inequity is characterized by wealth quintiles, which is one dimension of inequity. But inequity is not just a matter of having economic means. It can include other factors such as age, ethnicity, religious affiliation, marital status, or place of residence. So refining how we look at inequity will help program managers to better identify which groups are systematically disadvantaged. And where pockets of inequity exist will help program managers focus attention and resources. Structural barriers result in family planning programs not reaching all women equally across a country, but a combination of knowing which women and where they live can help program managers to better meet the needs of women and couples who experience inequity in access, availability, acceptability, and quality of family planning methods and program services. Our goal is for this methodology to be used to create an evidence base that family planning programs can use to better serve women and men. It brings rigor to an issue that we all care about, and it is a replicable analytic approach. The code to conduct the analysis is on the HP Plus website and can be downloaded by anybody free of charge. It is written in R, which is an open source programming language, so not having SAS or Stata or SPSS or any other analytic software package will not be a barrier to being able to use it. HP Plus is also preparing an analytic note to explain the methodology, as well as a policy brief that summarizes the findings presented here today. The Health Policy Plus project is committed to improving health equity, and the development of this analytic approach can be used to guide family planning programs in allocating resources, directing services, and bringing attention to specific segments so that women everywhere, regardless of their wealth, their residence or education, ethnicity or religion, can have the children they want when they want to have them. Bethany, I turn it back to you for question and answer. Thanks.
Thank you so much, Jay. We have some great questions rolling in. I'm really excited to get this discussion going. So the first one is from Ellen Starbird. She kind of had a comment and a question. This kind of subnational analysis is much needed, and the data visualization approach is terrific. And then the question is, can you please say more about the lack of data on availability? And did you consider data in the SPA?
I'm happy to take that, Bethany, or shall we, we're doing question by question, is that right?
Yes.
Okay, great. So thank you very much for that, Ellen. This is Kaya speaking. So in terms of the lack of data on availability, we were essentially looking for the types of questions that would as you alluded to, would be in something like the SPA or are actually collected by PMA 2020, which is whether or not a certain number of commodities are available at the facility level. So we weren't able to, at the initial part of this activity, we tried or thought about linking a SPA to the broader DHS survey, but didn't end up going with that approach. But in the current DHS survey that we actually used, there was just nothing that would give a sense of the extent to which commodities and services were actually available within facilities in each of the sampled areas. Kevin, anybody else, anything to add there?
I mean, just to say a bit more about the decision not to use a SPA, we did review all DHS and all SPAs for all countries available, and what we found is that frequently the SPA is not that close to a DHS, so even if there were a couple countries where it might have worked well for us, it wouldn't have been applicable to many countries.
Great, thank you so much for that. We've got several other questions rolling in, so I will start to read the questions two at a time, just for efficiency's sake. So next up is from Kevin Pills. How do we think about equity in the context of a total market approach and trying to segment the market and where people access services and commodities based on income? Next question is from Julius. Is there a chance that the code could be made available in other statistical programs and not just R? So I'll toss it to panelists to start where you'd like.
Jay or Sarah, any thoughts on the question about equity within a total market approach?
Great question, Kevin. And I think, let's see, the notion of the total market approach to me is really trying to align the disadvantaged, and in this case, generally, it's based on the economic quintile or the ability to pay with the different types of sources for family planning. I think that what we would need to do is really look at the other characteristics that we've included in the approach other than wealth to see how they align with source and kind of how they correlate with wealth quintile to see, because I think of TMA as really about kind of the financing and getting, to me, ultimately, it is about ensuring that public sector programs are directed toward the women that don't have recourse to commercial or subsidized programs, primarily because they can't afford to pay. I think it would take a little bit of digging, but like I say, there may be some correlations, and I think that would need to be looked at on a country-by-country basis.
And in terms of the code availability in other languages, so this methodology was actually done in Stata, but we have really been transferring everything over to R at the moment. But I think we could be open to providing it at least in Stata if there's such a need. So please do follow up with us over email if there's interest in that.
Thanks so much.
This is Shiza. I will add though that you cannot make maps in Stata, so which is why we wanted to include the R code with the whole package, because then the visualizations are not done in Stata.
Thank you so much for that, Shiza, Kaya, and Jay. I'll read out our next two questions. First is from Meredith. Thank you for this fabulous presentation. Since the metrics focus on the use of modern methods of FP, I'm curious how you account for women who choose to use traditional methods. LAM, standard days method, cycle beads. Are they being excluded altogether? How does this affect the outcome measures? Next is from Jordan. What if a woman is young, unmarried, and an ethnic minority? How were considerations made for women and girls who met multiple categories under the analysis? Over to you, panel.
Hi, this is Jay. Could I jump in and answer Meredith's question, because I think there may be some a little confusion. LAM, standard-based method, these are fertility awareness-based methods. They are collected by the DHS. Women who use these methods aren't considered to have an unmet need. And so that, calling them traditional first, I think puts them into a category that isn't correct. And so I think that the analysis would include these women as using a method, just like any other modern method that may or may not have been obtained from a provider, like a condom, pills may be obtained from a pharmacy or something like that. So while I wasn't involved in the analysis, and I'm not sure the extent to which the Uganda DHS tracks all of these methods, I think that it probably does. Using these types of fertility awareness-based methods would certainly be in that category of modern method use and demand satisfied.
Yeah, that's exactly right, Jay. In the DHS data, they categorize both of those methods as modern.
Kevin, any thoughts on when women meet or sit across multiple categories? So you did a little bit of looking into that.
Right, yeah, so the results that we showed are obviously just touching on a piece of a woman's identity. Most people will fall into multiple categories. There's actually very few people who would only fall into one. What we found is that 1.5% of the women for this particular survey had no disadvantaged characteristics, and 0.5 had all 7. If you just take people with 2 to 4 of the disadvantaged characteristics, that accounts for about 3/4 of the whole population.
Great. Thank you so much, team. I'm going to keep rolling to the other questions here. I'm just scrolling down. All right, there we go. So I'm going to read off the next 2. This is from Jennifer. Did the subgroups that experienced inequities, youth, unmarried women, minority ethnic groups, also have financial disparity when compared to other groups of women? Then the next question is from Maria. Great presentation. For what variables are the models controlling? Over to you, panel.
Yeah, so I think this first question on whether unmarried women, those who are less educated, if they experienced inequity and they were also impoverished, this kind of gets at the question that Kevin just answered. About 3/4 did overlap in which groups they fell into, but we did not look at this overlap. We basically isolated the influence of being uneducated on the specific FP component, for example, accessing FP services, to compare it to other disadvantaged groups. But we didn't look at the interactive effect because we wanted to get a number on, for example, being uneducated compared to those who are educated. The marginal effect, the marginal additional effect of being poor wasn't calculated here, so we didn't look at
that. Kevin, would you like to touch on the control bit?
Yeah. So as mentioned in our presentation, this was designed to figure out the who, what, and where of inequities in family planning. We didn't try to say why. So we did not do any controls beyond the all the various groups, controlling for each other. If we had, we might have missed an inequity between 2 groups. So we opted not to do any controls. So it does not answer why these inequities exist. It just shows who is experiencing them.
Great. Thanks, team. I'm going to keep rolling to the next 2 questions. Next up is from Fiona Amado. They're expressing some surprise that we didn't have a sample size for Karamoja, apologies if I'm butchering that name. What was the sample size needed and who led the team in Karamoja? And then the next question is from Karen Hardy. Thanks for sharing this work. A big gap in data on inequity is evidence that interventions improve equity. Is there anything about this approach that could be used for evaluating interventions? Over to you, panel.
Would you like to make a comment about the sample size issue, Shiza, or even Kristen, if you're on the line?
Sure. This is Shiza. On Karamoja, I think it's a little bit confusing because I said 100 women answered the question. So while in the actual DHS Karamoja, a lot more women were sampled, what we really needed is that enough women had to have answered the question for the family planning component we were interested in. So for one of the components, I believe is quality, there were only 43 women that answered that question in Karamoja. So we did not run the model.
Right, and that's because the sample is restricted in that regression to modern method users. So the reason the regression was not able to run for Karamoja for that aspect is because there were an insufficient number of modern method users to really focus on their quality of use.
And maybe I'll take a first stab at Karen's question. Thanks for that, Karen. So we didn't design this with evaluation of family planning programs in mind. I think it would be an interesting thing to try. For instance, if a program was active in a specific state but not in another, we could certainly run this in, again, if the data is available through the DHS in that state and compare it to another based on performance and try to draw out some conclusions about the contribution of the family planning program to those outcomes. But as you know, that would be very difficult. So it wasn't quite designed with evaluation in mind. I think if someone is interested in building some of these elements into their family planning program evaluation, they could certainly use some of the methods from this approach to customize something for their own purposes, especially if they are doing some sort of surveying of their intervention areas. Would
Thanks,
anyone
Kaya.
on the team like to add to that? Okay.
All set? All right, we'll move along to the next two. This is from Betty. So if all subregions have inequalities, what advice do you give in terms of policy and programming? Thanks for that, Betty. And then next is from Bev Johnston. Besides making the model publicly available, does the project have any additional dissemination plans? Over to you, panel.
I think the advice we can give, as we touched on in the presentation, is a bit more specific programming and tailoring of interventions to subgroups and their needs. So for example, there may be subgroups in specific subregions that have issues specifically with FP quality. And so the government can focus in future CIPs or future FP commitments that it makes on interventions that, for example, target youth in specific subregions to improve the FP quality in those subregions.
And I just want to add to that, actually. So if we go back to some of the maps we use, actually, I'm just going to try to go back a little bit, or even the results for Bunyo and Bugisu, we recognize that there are just so many results that exist through this analysis. And that number of results increases if you have even more subnational divisions. So it is quite an overwhelming amount of information to process. I think in order to really make it work for you, the important thing is to focus either on the regions that are most of interest, the subgroups that are most of interest. So try to segment out or divide up the findings in a way that is kind of most helpful for your purposes. So if you're a stakeholder who is working on family planning programs in Acholi, for instance, or in one of the districts in Acholi subregion, then reviewing these results, all of the results for Acholi would be, a way to really begin thinking through the programming implications. And as mentioned, those results for Uganda will be made available in a brief. So you will not only have the results by each sub-region for these two areas of family planning. And as a reminder, this is access to information, and the second one was demand satisfied. But you'll have the full 5 components available for each sub-region, and you'll also have a sense for each sub-region that is affected with inequity, who the women are who are experiencing inequitable outcomes. So that will hopefully prove very helpful for programming for both public sector and NGOs, et cetera. And I believe Bev's question was about additional dissemination. So one area that we saw where this could be incredibly useful would be for the next generation of costed implementation plans. So while we haven't gotten there yet, we certainly will be hopefully speaking with the Family Planning 2020 Cost Implementation Plan Working Group, also within Palladium and Avenir Health, connecting with CIP colleagues and making sure that this informs not only CIP commitments, but the actual program activities at subnational levels. Anything to add from the team?
This is Jay. Bev, great question, because we always look to get new innovative tools and approaches out as broadly as possible. I'm not sure if anybody from the ministry or any of the family planning stakeholders in Uganda are on this webinar today, but we'd be certainly open to doing kind of a command performance that may drill down a little bit deeper or differently into some of the results, as well as reaching out to the Uganda team at USAID. In addition, I think that we'll be looking for opportunities to present the methodology and the results in other webinars, seminars hosted by other organizations, because the whole issue of equity continues to be an important issue that not just HP Plus, but I think the whole PRH agenda attempts to improve on. So any thoughts, any opportunities that you come across, we'd be welcome to try to disseminate through those opportunities. Thanks.
All right, thank you. I'm noticing that we're getting a little bit close to the end, so this will be the last batch of 2 questions. And we just want to thank the audience again for such an engaged question and answer session. We appreciate you so much. So first one is from Ishrat Hussain. Excellent analysis and presentation, very useful. This type of analysis is needed for all countries. I think it will be useful to share with missions in some short form. PRB has done this analysis for Africa Bureau focused on economic aspects. This one is a great compliment. My question is, are there inequities in attitude of men towards family planning? And I'm just going to scroll down here and grab the next one. This is from Jill Peterson. How does this analysis complement the WHO HEAT tool, Health Equity Assessment Toolkit? Over to you, panel.
Thank you very much for those questions. Ishrat, in terms of inequities and attitudes of men, unfortunately, we didn't look into that here. We didn't choose to look at the attitudes of men, but that certainly would be an interesting kind of additional family planning component to include here. As you saw, the 5 family planning components that we ultimately selected were not only limited by the DHS survey, but we really tried to represent those AAAQ and outcome elements as closely as we could. But of course, this attitudes of men would certainly be interesting for the acceptability element and others. So that's a great suggestion if we want to look at inequities a bit deeper. So in terms of the heat map, any responses from the team? Lubov, I remember that. I think I know we took a look at this, but I'm
right. Yeah, so my thought is that, you know, the heat map and to some extent other tools, even the SGGs, for example, there's been a move towards disaggregating indicators and looking at, you know, for example, childhood immunization by different groups. For example, childhood immunization among the poor versus the rich. I think these tools are really useful to look at, point estimates in various countries and to compare point estimates across countries. And I think our approach here could be useful to dive deeper into countries and to look at the inequities in a more detailed way, specifically for family planning, because I don't believe the HEAT tool goes into much detail at all into looking at inequities in family planning across countries. So I think this could certainly be a complement to something like the HEAT tool.
Great. Thanks, Lubov. Well, we are just about at time, so we are going to sign off here. I just want to, again, give a huge thanks to our panelists for preparing and delivering this tremendous presentation, which has been recorded for you and will be made available on the HP Plus website. Huge thanks to our audience for a really engaged Q&A session. And again, thanks again to Sarah Stratton, Kaya Yurchinska, Kevin Ward, Shiza Fareed, Lubov Teplitskaya, Dr. Jay Gribble. Have a wonderful rest of your day and evening, everyone. And thanks again. Take care.